Let me just confirm if you're live.
It says you're live.
Let me just confirm that now that's checking the link. It's supposed to be live, but it's not showing up here. Don't know why. Still This one says live here. Okay, we are live. So I guess we can start the lecture.
Let's get that opened too.
And go ahead. I'm just copy to send you.
Hi, everybody. It's Dr. Ben. Sorry for the delay. We had some getting online issues. This is basically a short lecture on vaginal bleeding, how we handle it in the ER. I trained, just a little background, I trained at St. Barnabas Hospital in the Bronx in emergency medicine. I'm board certified in emergency medicine. And I want you to know the information that I have here today is on the internal medicine boards. I will have some summary sheets for you in this lecture that you can use as a study guide. So let's get started. Here are the goals. We're going to talk about what are the causes of vaginal bleeding. Most of the lecture will be occupied by those of the age to get pregnant. So we'll talk about minors, children of bearing age, and the elderly. Okay, next. The purpose of this presentation is to review what is the workup that we do for someone who presents to the emergency department with vaginal bleeding. It is not, I'm going to say that again, it is not a comprehensive OB-GYN review. Not every cause of vaginal bleeding is going to be reviewed in this lecture. Remember, in the ER, I always state two things that's the most important. One is rule out life-threatening emergencies, and the other is time management. You need to run your ER. Okay, again, this has been on emergency medicine and internal medicine boards. So what are the causes of vaginal bleeding? In the minor patient, there are basically three reasons to consider. Child abuse is number one. A foreign body, self-inflicted, the child put in a pencil. And hormonal imbalance, like congenital adrenal hyperplasia, for example. If you are suspecting child abuse, you must act on it. Your license depends on it. You must notify the appropriate people, the police, child protective services. Now, the caregiver in the ER with this patient does not like to be called an abuser. So you explain to the caregiver that the law requires you to notify the authorities and that you are not making any judgments or accusations. You're just doing your job. Vaginal bleeding causes. In the patient of childbearing age who is pregnant, you must consider the following. Ectopic pregnancy. I'm going to say that again and again. Ectopic pregnancy. You must consider abortions, and for the boards, you must know the different types of abortions. You need to know about placenta previa, placenta abrupta, and labor and trauma. Those are the basic causes of vaginal bleeding. In the patient of childbearing age who is not pregnant, you must consider the following. Is it menses, dysfunctional uterine bleeding, fibroid uterus, neoplasm, and trauma? In the elderly, this is important. Please get this. You must think of neoplasm first, then consider other causes, trauma, or also hormonal. And here's a kicker. We see this in the ER all the time. An elderly woman comes in complaining of vaginal bleeding, and as it turns out, it's hematuria. Any elderly patient who comes in with vaginal bleeding, you must think neoplasm first. You must put a finger in the vagina and look at your finger to see if there's blood. Very often there is none, and the problem is hematuria. Very common. Regardless of the cause, all patients, regardless of their age with vaginal bleeding, you must arrange a follow-up with gynecology or obstetrics. You have to decide, do I need to do this follow-up stat or routine? Some questions that you need to ask. Are you pregnant? When did your bleeding start? Is it constant or intermittent? Are you having pain? How long have you been bleeding? How many pads, tampons, frequency? Are you on birth control? These are your basic questions that you must ask to form a differential. History, history, history. How many times have you heard that? So from the point of view of the emergency department, if the patient is not pregnant and they're stable, you get them out. It may be dysmenorrhea. It may be menorrhagia. If they're stable, they follow up. You can call it dysfunctional uterine bleeding, and you arrange a follow-up with gynecology. They may have 1,000 questions for you. We rule out life-threatening. If there's nothing life-threatening and they're stable and they have vaginal bleeding, we are done. Just arrange a follow-up. This is the most important stuff. You need to rule out life-threatening emergencies. That's what we do in the ER. An ectopic pregnancy, placenta abruptia. You may note during your ER rotation that we don't do pap smears. Cervical dysplasia, although not good to have, it's not life-threatening immediately, and therefore that's an outpatient follow-up. We do not do that test. We do, that didn't sound right. We perform tests for STDs or STIs. For the remainder of this presentation, I need to concentrate on the childbearing age who is pregnant and has vaginal bleeding. Pregnant vaginal bleeding, the alarms should be going off. You have to order some tests. First, you have to make sure they're stable. You may need to put them on the monitor. You order an HCG, qualitative. First, you need to confirm that they're pregnant. If they're negative, what is it? Dysfunctional uterine bleeding, and they can follow up as an outpatient if they're stable. Now, what if it's positive? Then you go to your next step. You must rule out an ectopic pregnancy. I cannot emphasize this enough. Abdominal pain, pregnant, they have an ectopic until you prove they do not. You must order the following. You order a beta HCG. the quantitative. You need the number. How pregnant are they? You do a type in RH. I want you to think why. We're going to discuss that later. An ultrasound, rule out ectopic. You may need some additional tests. CBC, BMP, PT-PTT, IV fluids, blood products, and monitor. Again, they have an ectopic until you prove it is not. I have some questions for you to think about, and we'll address them later. At what beta quant level can one expect to see evidence of an IUP, that's an intrauterine pregnancy, on a transvaginal ultrasound? What's the beta quant for an IUP transvaginal? Next question. How many weeks gestation must you have to be able to see anything on ultrasound? Why do you order a type in RH? If the beta quant is less than 500, do you even need to order an ultrasound? What's the leading cause of pregnancy-related fatality to the mother in the first trimester? What about some answers? Beta has to be around 2,000. I usually say 1,500 to 2,000 for you to be able to pick up an IUP or a gestational sac or some kind of proof that there is a pregnancy in the womb. Using transvaginal sonography, in normal intrauterine pregnancies, there is what they call the intradecidual sign, can be seen at 4.5 weeks. A secondary yolk sac may be seen at 5.5 weeks. And a good question for the boards, how many weeks gestation should there be cardiac activity detectable? Please know that. How many weeks of gestation does it take for cardiac activity on ultrasound, transvaginal, to be detectable? Let's go over some answers. When you think RH, you think RhoGAM for the RH negative mother. If the mother is RH negative, it means she does not have antibodies. If the fetus is RH positive, she will build antibodies against that. That will affect the next child where her antibodies attack the next fetus. So that's why we get the RH. If it's negative and there's bleeding, we give RhoGAM. Not Rogaine, RhoGAM. What is the leading cause of pregnancy-related fatality in the first trimester to the mother? It is ectopic pregnancy. Now, how do you do a disposition on a patient that does have an ectopic pregnancy? That's going to depend if it's stable or unstable. If the patient is stable, you speak to a gynecologist who may tell you about administering methotrexate and arranging a follow-up. You will transfer that patient as necessary. The unstable patient, when you're in our ER, here at St. Francis, we have another facility that is on call for us. It could be Capital Health, Hopewell, or it could be Robert Wood Johnson in Hamilton. The unstable patient, of course, is being, you already have their type in RH, you may have to give blood and fluids and transfer them out. I have a question for you. If you have an unstable patient in your hospital, anywhere on the floor, and they are unstable, can you transfer them out, or is that an EMTALA violation? We'll talk about that later. Some important facts. If there's a positive beta, regardless of the number, get that ultrasound. Ectopic is still possible. Do not say the beta, oh, it's only 400 or 500. You're not going to see anything anyway. That's the biggest mistake of your life. It could still be ectopic. Do not assume early pregnancy. This patient is going to need serial beta quants, and ultrasound is a must. And you must arrange a gynecology follow-up and document that in the chart. I'm just checking the time. Good. Now we're going to move to the next subject, abortions. You can always leave questions for me. I'll get them in the emergency department, and I will get back to you if you have questions. An abortion, 20 weeks or less is an abortion. If it's more, it is a miscarriage. That's how you define it. You must, now this is the stuff for your boards, you must know all 5 types of abortions. You should be able to discuss what are the trends. What are the trends of the beta? What's the most common type of abortion? Which type has an open cervical os? Which is closed? Dr. Khalid, they can see the slides?
Yes.
Okay. You're going to love this stuff. All right. There's a missed abortion, complete, threatened, incomplete, and inevitable. You must be able to discuss these 5 classifications and compare each one to the other. All right, I have some questions for you. What is the difference between a missed abortion and a complete abortion? Missed abortion still has an IUP on ultrasound and there's no fetal heart rate. The complete, there's no IUP on ultrasound. All right, complete, that uterus is empty. Missed is what we used to call fetal demise. Both have decreasing betas, possibly 0, and both have a closed cervical os. Moving on. Which of the 5 classifications of abortion is the most common? And is the cervical os open or closed? I wish I could see all of your results, but I know you all put a threatened abortion. Threatened abortion is the most common and presents with the following. The beta is up or down, the os is closed, and there could be an IUP or maybe not. You will know more about it if you had a beta from before to compare. Os closed, bleeding, pregnant, or not. Or not pregnant right now, but there's a positive beta. Okay. More questions you need to be able to answer. What's the difference between incomplete and inevitable? Notice I underlined the I's. That's going to help you on your test. What's the difference? Hopefully you're thinking about this before I give you the answer. The answer is the products of conception. That's it. If the products of conception are still there, that's incomplete. If you do not see products of conception, the cervix is wide open. Let's go through it. Both have an open os. Incomplete and inevitable have an open os. There's your results. You're going to have a low HCG, the os is open, and there is no IUP on both of these. The product's conception gives you your answer as to incomplete or inevitable. Inevitable, there's your beta. The os is open, but there is an IUP. But it's inevitable that they're going to abort. Here's your chart. You're going to want to copy this, make a card out of it, copy it, and test each other. I'm giving you your board answers right in front of you. All right? So I don't think I need to read each thing on this chart. It's for you. But just the bottom. Remember your I's and O's. If it begins with I, there's an open os. So you'll know if you have an open os, it can't be a threatened abortion. You can make up so many questions from this chart. I may ask you to compare an incomplete with a missed abortion. All right? Incomplete, there's an IUP. Missed, there isn't. Okay. A very important slide. I suggest you copy it. Two other emergencies that we have to deal with, possibly in our emergency department. Placenta previa and placenta abruptia. All right, this is a positive HCG and an IUP, placenta previa. It's a complication in pregnancy. The placenta grows at the lowest part of the uterus or womb, and it covers all or part of the opening of the cervix. This is, you need to remember two things on placenta previa. It's painless and it's bright red. The bleeding is bright red. Do not do a pelvic exam on this patient. You get an ultrasound and you call OB-GYN. If you hear me say do not do a pelvic exam, because you are not to do a pelvic exam, you get an ultrasound and you call OB-GYN and you get them out. Hopefully they are stable. Here's a picture for you. They're showing you there's the normal placenta where it belongs, and you see the cervix. And in the other picture on the right is the placenta is low. Abruptia is another story. This is life-threatening. The person can bleed out, exsanguinate, become hypotensive. And I did have a patient like this once on an ambulance where I worked, and we used MAST trousers. It was wonderful. We don't have them anymore. M-A-S-T, MAST trousers. It was a military anti-shock garment. Trousers. Okay, this is different. This is different than placenta previa in that it is painful. And there's dark maroon bleeding. But here's a trick. Depending where the abruptia takes place, there may not be any bleeding. This is where you do your history and your physical. You know she's pregnant and going into shock. The belly is really tight without bleeding. That's a good assumption to make. Call OB-STAT and treat for shock. Transfer this patient out. So there's your abruptio placenta. For the boards, here are some questions. Here they ask again about painful and dark, abruptia, and bright red and painless, bleeding. 1 out of 800 deliveries can be an abruptia. 1 out of 200 is placenta previa. Here's another page. You need to remember this chart. These are the causes of placenta previa and abruptia. Let's do previa first. An abnormal uterus, multiparity, a large placenta, scarring lining of the uterus. Maybe they had a classical C-section, and that could lead to previa. Now, abruptia, the first thing I put there is cocaine. Cocaine, #1 cause for placenta abruptia. They may also have a clotting disorder, cigarette smoking, diabetes, alcohol, high blood pressure, fibroids, and premature rupture of membranes. Multiparity, a history of abruptia. This is another slide I want you to know for the boards. There you go. We're getting to our summary. I got plenty of time. Maybe I'll just let you think for a while. No, I'm just kidding. Just kidding. All right, in the ER, a person comes in with vaginal bleeding. You do a urine and you find out if they're pregnant. Once you do that, you can come up with your differential. If she's pregnant and she's in shock, it could be abruptia. That's the first thing we do with our pregnant patients. Patients that come in with vaginal bleeding. You need to know because you need to rule out some things that we talked about. If they're not pregnant, this is great. We like this patient. You know, we let them know we can do blood work. If you need blood, we can transfuse. But basically, this patient has to follow up with gyne. If they're pregnant, and this is it, I hope I've emphasized this a lot. A pregnant patient needs the basic labs, including an RH, as we talked about before. And you need to rule out ectopic. Ectopic. The minor patient, basically, it's foreign body versus abuse, which you might have a question, basically, what do you think about vaginal bleeding in a minor? These are the two main things that you need to think about. In the elderly, it's neoplasm or trauma. If it's trauma abuse, you call the police and adult protective services. The abortions. Know your I's and O's. If it begins with an I, it has an open os. Don't forget to type in RH. And you need to know why. Placenta previa and abruptia, the pain and the color. I don't know why they make such a big deal over that, but that's always been on the boards. Don't know why. Oh, look! I became a fellow of the American College of Emergency Physicians in December 2010. Woo! So that's it. You know, if I could just leave you with a thought to make sure you don't forget ectopic. It's the #1 killer for the mother in the first trimester. And the abortions, the classifications, the I's and O's, and your disposition. What are you going to do with these patients? I am done, and I wish you all to be safe. And I'll see you in the ER. At some point, I'll catch you in the ER. Trust me. I wish you can see my face. That's it. What do I do?
Oh, I don't see any questions. So we can. Okay. Thanks a lot, everybody.